Good evening, everybody. My name is Dr. Mei Cheah. I am one of the obstetrician, gynecologist, and a fertility specialist here at Melbourne IVF. Hello. Hi, Julie. Hi, Victoria. Thank you for tuning in. I'm just going to wait a little bit to give people time to log in. Just to see whether I'm going to get an audience. This is my first Melbourne IVF Facebook Live, so please bear with me if I'm new to this and finding my way around orientation and to see where things appear and stuff. If you do have any questions that you want to ask, do send them through to me in the comment box. And I'll try my very best to answer them. While we start and wait for people to tune in, I'm gonna introduce myself a little bit. Like I was saying before, I'm one of the fertility specialists here at Melbourne IVF, and I'm also a co-director at a holistic women's health group called Create Health. This group is formed by us 4 directors who are also my family members. Oh, I call them family, but they're really like my work family. And we had this vision of forming a holistic women's healthcare practice, which is where we are now. So if you want to look up my bio, I am available at Create Health, and that's C-R-E-A-T-E, Create. I work in private and in public. My public appointment is at Monash Health, and I work in both obstetrics and also gynecology. Hi, William. Excellent. Hi, Tom. Yeah, so I work both in obstetrics and gynecology, and I am on call there as well. Hi, Twinkle. How are you going? Thanks for tuning in, people. Really appreciate the support. I am very passionate in women's health, and after completing my training, I decided that I wanted to be a strong advocate in the field, and recently has been chosen as one of the influential women in STEM. So I am hoping to continue to empower and educate not only women, but everybody in regards to women's health. And what I want to talk about today is a little bit about us as women, whether you identify as one or not. So basically anyone who has ovaries in regards to our fertility assessment and fertility preservation. There's been a lot in the media lately in surrounding the fertility field, and I would like to address some of that. Allow me to start with something basic. And often when somebody comes to see us in clinic, sometimes we get asked about, you know, I have this issue and this issue, but am I going to have any problems with my fertility? And my colleague Alice last week, do they? Hi Jay, tomatoes have ovaries. I did not know that. Thank you for that. And yeah, Alice said last week that the best test to see whether or not you can achieve a pregnancy is by having the baby. So the baby is the best test. And I thought, Yeah, there is no other better way than finding out whether or not you can achieve a pregnancy unless you have a baby. But there are some ways of us getting an assessment on what the chances are for us. And this would generally involve an individualized appointment that you have with your specialist to go through a series of questions and investigations with you. Can you freeze your eggs if you have low weight? Yeah. Okay. So just answering Julie's question, the AMH level, so anti-Müllerian hormone, is one of the ways that we can test for our egg quantity. It doesn't actually tell us what the intrinsic egg quality is. And we know that that declines with age. It declines after we hit 30, and then further declines after 35, and rapidly declines after 38 and 40. There are other conditions that may affect the AMH level as well. Things like endometriosis can lower our egg count, or anything that affects the ovaries if we've had previous ovarian surgery, if there's been a cyst that we have removed previously, and along with that we've taken some ovarian tissue, can lower our egg count. And that can be done with the AMH test. So the answer to that, Julie, is yes, you can freeze your eggs if you have a low AMH, but you may require more cycles to achieve the number of eggs desirable for us to be able to achieve a pregnancy and a baby at the end of it. Generally, in the cycle of egg freezing, going back to Julie's question, when we freeze, we will need to undergo a stimulation cycle, and that is by us giving you, let me see, I'll block out the brand there, stimulation in the form of FSH, and that's called follicular stimulating hormone. The dose of it can be dialed up according to what your fertility specialist feels you need. And that's in conjunction with having done a pelvic ultrasound scan to look at your, what we call your antral follicle counts. So how many follicle can we see on the ovaries, your history, your age, and your AMH level. And that will give us an estimate of what we think the best stimulation dose would be. In general, to enable us to have at least a 50% chance of achieving a pregnancy or a baby, you want to be able to store approximately 20 to 30 eggs. Storing the number of eggs is not the same as storing the number of embryos. Yeah, so you've got to take into account that each step of the way, you will lose numbers. The number of eggs does not equal to the number of fertilization that you'll have, does not equal to the number of embryos that you'll have at the end of the cycle, which means it does not equal to the number of babies. So it's very important to bear in mind what the expectation is and to have an open and honest discussion with your fertility specialist when you embark in the egg freezing cycle. Well, I have no eggs again. I had 10 follicles, but no eggs. First time I got 33. Oh, I'm so sorry to hear that, Jade. It's difficult to say why sometimes we get no eggs during a collection or a stimulation cycle. By the sounds of it, you had good amount of follicles, but we need to make sure that the follicles are of an optimum size, so they can't be too big or too small. So the timing of when we collect the egg is important, and that's why we are very naggy when we say you got to take your trigger at this time, you got to take your trigger at this time, you got to have your egg collection at this day at this time, and don't don't get the protocol wrong, because sometimes that can result in us getting no eggs. Occasionally, the ovaries can be sitting in a tricky position, that even though we can see the follicles and the supposed eggs that are in the follicle, they are not accessible for us to retrieve them. Most of the time when we do egg collection, we do them vaginally. So when the ovaries are stimulated, they are very big, and so they hang quite low and very close to the vagina. So when we do the internal scan, which you would be very familiar with if you're undergoing a cycle, when we do the internal scan, they are literally, the ovaries are sitting very close. And so we use very fine needles to aspirate the follicle fluid to then obtain the eggs that is sieved through by the clever scientists. So I would suggest perhaps doing a review of what your protocol was to see what has happened. But I'm so sorry about that. So the first time you had 33 eggs, Jade, and I'm hoping that the interval between your cycles were not too far apart, so we haven't, our egg quality hasn't aged all that much, which should mean that we should be able to get eggs with your next cycle. We may just need to tweak your stimulation protocol a little bit. Sometimes we may add LH or but that's certainly something that you can discuss with your fertility specialist. Yeah. That's a very interesting question, Pei. We do sometimes do that. That's part of the add-on. But like I said, again, that is something that the lab will generally go through with your clinician and yourself as to why the fertilization result was poor. Sometimes we find that it is the eggs that are fragile, or maybe we would want to see that, you know, it is the right FERT method for you, whether you're doing just an IVF FERT or whether you're doing IVF ICSI or what it is that you're doing. Some fragile eggs don't inject very well, and that's something that you can certainly discuss. I had surgery for stage 4. Oh, Kate. Thank you for posting that question. That is actually a very, very important question. And in regards to fertility preservation, that is something that we always want to put at the back of my mind. Given that we are a laparoscopic surgeon and we see people with endometriosis a lot, I can tell you that, you know, we operate on endometriosis patients a lot. And a lot of the time, you're kind of at this point where you go, do I want to treat the pain and then suppress the endometriosis, or do I want to have a baby and go for the fertility side of things, because one will compromise the other. But when we see somebody, even though they're younger, with endometriosis, and then we want to do clearance surgery, we have to bear in mind and discuss this with our patients that, let's say, if there is endometriosis in the ovary, that's called an endometrioma. When we take out endometriomas, inevitably we will take out some ovarian tissue with that. And even though at that point in time it may not be something that they're thinking, oh, am I, you know, going to be able to have a baby? It is a discussion that we always have with them, that do you want to have a cycle of IVF if you haven't got a partner to do egg freezing? A lot of people call it social egg freezing, but in my opinion, is it really social if every day that we age, our egg quality declines, I believe that the indication of egg freezing is more than just social. It's just a term that doesn't sit well with me. And I like to look at it as an insurance policy. You may not need it, but it's good to have it. It's not without risks. The process of egg freezing does require you to go under sedation to have your eggs collected. And sometimes you can have what we call ovarian hyperstimulation syndrome, where you get too many eggs, and that can make you feel unwell. In a very, very, very rare circumstance, sometimes patients end up in ICU, that sort of unwell, but that's super rare. But is it really social? I do not believe that egg freezing is just social. Every day that we do not have a baby is a day that we lose in terms of our quantity of egg and also potentially our quality, because as we age, our egg quality goes down as well. But Kate, having stage 4 endometriosis does not mean you can't fall pregnant, but age is not on our favor, being 42. So if I were you, I would, seek help from a fertility specialist, or at least have that discussion. Yeah. Is 250 high dose for menopause? Hi, Jade. The dose of stimulation is very dependent on, like I was saying before, your follicle count, your age, and what your previous cycle has been like. But in general, 250 is not high, and we don't tend to overstimulate with 250. Yeah. What is the meaning of multifollicular ovaries? What is the difference between multifollicular and polycystic ovaries? Yeah. So Twinkle, that's a really good question. Polyfollicular ovaries and multifollicular ovaries and polycystic ovaries technically mean the same thing. We used to call them polycystic ovaries, but then often that gets confused with polycystic ovarian syndrome. And for you to have PCOS or polycystic ovarian syndrome, you need to have other things like irregular period cycle, or increased facial hair, or acne, or hair elsewhere on your body. And you may also have an increased level of androgens, which is the male type hormone, we loosely call it. Having that and having a polyfollicular ovary scan, you need to have 2 out of 3 of that for you to have PCOS. So now we're trying to steer away from calling just having many follicles on the ovaries. We're trying to steer away from calling that polycystic ovaries, so PCO. We're trying to get away from calling it that, and we're trying to rename it multifollicular ovaries. So in the absence of all the other symptoms, having multifollicular ovaries does not mean that you can't have a baby or you will have any issues with your fertility. In fact, we love it in the IVF world because it just means that you may have more eggs for us to collect. As my partner has to undergo testicular surgery to get the sperm by his specialist, does this translate to one with fresh egg transfer? Am I able to freeze some also? You're probably going to be able to freeze. Usually we try to time the surgical sperm retrieval with your egg collection so that they can be fertilized together as what we call a fresh transfer. This generally, if we have to get surgical sperm, it will be done with an ICSI cycle. But depending on how many good sperms we get and how many good eggs we have, if you have a good number of fertilization and a good number of blastocysts, you will be able to freeze some for your next freeze cycle for your next baby. Yeah. Oh, thank you, Hader. That is so lovely. Yeah. That's, yeah, my lovely colleagues there are showing me support, so I'm very happy. Now, going through IVF, what can I do to the ups and downs? Oh, there's no apologies needed regarding the tomato post. I thought it was pretty funny. Yeah. Yes, being the partner when your significant other is going through IVF, whether it's your wife, whether it's your girlfriend, your partner, it is an incredibly tough position for you to be in, because you probably feel like there is nothing you can do except for maybe provide some sample in a jar to support her through it. And unfortunately, the cycle is designed in a way that regardless of the factor of the infertility, whether it is male or female, or in a percentage of them, it's no obvious factor found. So, unknown cause. The female will still need to undergo the stimulation and the egg collection and the embryo transfer. So my advice would be kind to her, be understanding, and be there with her every step of the process. During COVID, it's been a bit tough because there's been restrictions put in place, and sometimes partners can't attend appointments or procedures, which is incredibly tough. But this week we've had good news. Us metropolitan Melburnians have got a little bit of easing in our restrictions and what we can do, and I'm hoping that this will continue to be the way. And my advice would be to be supportive every part of the journey. It is very important to be on the same mindset and to have the same goal, because IVF can be an incredibly emotionally draining process. It is full of ups and downs and full of uncertainties, and there is no better person to support you than your significant other who's trying for this baby with you. So good luck with that. Jade, you also have one tube and PCOS. Yes, having PCOS does not necessarily mean you can't conceive. We usually try something called ovulation induction, and this can be done with a medication called Clomid or letrozole. And sometimes when we have too many follicles on that, we can convert the cycle to an IVF cycle to collect the eggs as well. Having said that, Jade, I suspect what's happened is probably you're probably not the easiest person to stimulate, because sometimes the follicles, there are lots of follicles that are sitting there with PCOS, but they sometimes don't get the message to grow, or sometimes they don't grow at the same rate. So I wish you good luck with your next cycle. I hope you get more eggs. Can you please read? Can you? Oh yes, sorry, Jenny. Yes, I will do that. And Pei is saying, thanks for answering my question. What causes multiple failed embryo transfer? That is a very interesting question, but a very, very difficult one to answer. I am assuming, and this is being very, very presumptuous, that we have good amount of eggs and good quality eggs, and we have good sperm, and together they make a good quality embryo or a blastocyst. In general, what we do now is a single embryo blastocyst transfer, and the quality of the embryo is there. It is already made, it is ready, it is beautiful. Then you want to make sure that the womb is receptive and optimum in receiving the pregnancy for it to stick. When we do the embryo transfer, we use this medium that is called Embryo Glue. It's high in hyaluronic acid to give the environment its optimum chance for the embryo to stick. But it's not really a glue. There's no real glue that will make anything stick, unfortunately. You would want to make sure that there is no pathology that is sitting inside the lining of the womb. So things like a polyp or a fibroid that is squishing the lining of the womb can impair implantation. So you want to make sure that the lining is nice and smooth and regular, and it's thick enough to be receiving the pregnancy. You then want to, the embryo, I mean. Then you want to make sure that there's no infection or any inflammation in the area. If in this instance that you've had multiple failed transfer of good quality embryos, we sometimes want to do this test called the ERA to see whether or not day 5, which is generally when we do the transfer, is your optimum time for your womb to receive the embryo. This test is generally involving us taking a little sample from the womb. It gets sent overseas to Spain to get processed, and it's quite costly. I think it's 1,400 or 1,500. Don't quote me on that. It's approximately that. And they will give us a report that comes back and say, the best time to transfer this embryo is day 4 or day 6 or day 4.5 or yeah. So that would tell us, give us a better chance that we are transferring when the lining is at its optimum condition. There's also an additional test that we can do that looks at the microbiome. So basically the bacteria or the ecosystem in the womb, and in some instance we may get you to take some probiotic or an antibiotic to optimize the condition of that. You just want to pretty much give yourself the best chance. Sometimes we will take a very comprehensive history from you to look for any other autoimmune condition, so an immune condition where your body can make antibodies to reject or attack the embryo. And in some instance, we may need to give you some medication to dampen that immune response so that the embryo will then be received and stick. Hello, I've heard about egg timer test. Can you explain what this involved and when you would recommend getting the test? Hi, Kelly. I'm assuming that test that you're talking about is the AMH level. It's a test, it's a simple blood test. It tells us the egg reserve that you have. So in some ways you can say that it's a timer. It doesn't tell us about the quality of the egg though. The natural cycle of our egg quantity and quality both actually, it reduces with age. So the quality and quantity declines. So there is a graph where it tells you that if you're aged this, your egg timer or your egg reserve should be around this level. And if you fall under that, then you're lower than what we would expect for your age group. And in that instance, we would urge you to either try and start a family as soon as possible, or if you are not ready to start a family, then the option of collecting your eggs and freezing the eggs, it should be discussed with you. Having a young egg that you have frozen from earlier before will give you a better what we call an aneuploidy risk. So let's say I'm 40, which I'm not. let's say I'm 40 and I have put in an embryo that I created when my eggs were 28 years old, the risk of that pregnancy having affected by Down syndrome is lower compared to if I am 40 and I have a 40-year-old egg and embryo created. The risk of you in pregnancy, risk like diabetes and blood pressure and all that does not change though. So there's some element of your pregnancy that you can alter, and there's some that you can't. Yeah. Thank you, May. No more tomatoes on my salad. I love tomatoes. Jade, I'm so sorry for that. Hubby had to do everything. I had to go into hospital 8 times. Like I was saying before, having a supportive partner is so important. And whether or not you're a single woman doing this yourself, telling a friend or telling somebody who is going to be supportive of your decision and your journey is important. I feel like we're human beings and we need an outlet, and whatever it is, whatever the outcome of the process may be, whether or not it's going to be a positive result, a negative result, joy, disappointment, having someone who is going to support you is crucial. Whether or not that somebody is a fertility specialist that you gel with, or a friend or a family, just anybody, yeah. Last round, 33. We thought one missing chromosome and other had Downs. Yes. In terms of having embryos and then having them tested, so that's called PGTA, where we test for aneuploidy or like you said, commonly known as Down syndrome testing. We sometimes do recommend that. One, if you have family history or if you have someone who's been affected, or if you're of an older age where your risk of having a chromosomally abnormal pregnancy is higher, we will generally say test, but we don't have to test everybody who goes through every cycle to do pre-implantation genetic testing. It is a personalized decision that you make after having a thorough discussion with your fertility specialist. There is no absolute right or wrong answer. Ultimately, you are empowered to make decisions about your own health and your own journey. And there are patients that will have the same circumstance, and some will choose to test and some will not. But if they are instances where we would highly recommend testing. Yeah. Hi Jenny, what's your advice on supplements, and what can you take to optimize your chances? Supplements are sometimes what we call add-ons. They are things that will not cause harm, but we are not exactly sure whether or not they cause significant benefit. But we generally say that they are safe to take. Things that are proven to increase quality of eggs and sperms are things that are high and rich in antioxidant. Oh, 7:38. I'm running a little bit over time. Things that are high and rich in antioxidants. Yeah, so in general, we sometimes recommend people to take coenzyme Q10, zinc, and other pregnancy supplements, things like folic acid or folate. We generally say is safe to take. There are some herbs that a lot of my patients take, like Chinese traditional herbs, and most of them are relatively safe or does not cause harm, but I would generally leave it for the traditional Chinese medicine person to give them specific advice, because I do not want to give advice in an area that I'm not an expert in. So yeah, definitely have a discussion with your specialist. They may not offer that as an initial, advice, but I'm sure they're more than happy to have that discussion with you if you ask that question. And they're things that, like I said, do not cause harm. So we're more than happy for you to take. And we do understand that sometimes the journey is so important to you that anything that may be potentially helpful is helpful. Yeah. All right. No problems at all. Thank you, everybody, for your lovely comments. I really appreciate you taking the time of this lovely evening to have a chat with me. I'm sorry I can't give everybody personalized medical advice, but what I wanted to touch on is that your fertility is your decision. There is never too early a time for you to take charge of that decision. It may just be education. You just need to empower yourself with the right information for you to then make informed decisions on what you want to do with your fertility journey. And the other thing that I want to touch on before I leave you guys for tonight is something about fertility preservation. This is something that is dear to me because it's not something that has been available for a very long time, or what I would say readily accessible. It is available, but it hasn't been readily accessible and well known to people, and that's fertility preservation. Especially when you get diagnosed with something that is completely devastating, like a cancer condition, and you have to undergo chemotherapy or surgery or radiotherapy. The first thing that you can think about is cancer and am I going to live? What's going to happen to me? And we often forget about our fertility until years later, and you go, why was I not given that chance to preserve my eggs, or freeze embryos, or some ovarian tissue that we can later on graft back into your body. And I just wanted to highlight that that is available. Your cancer specialist or clinician should be having this discussion with you. And this is something that we're trying to get out to the wider medical community, that collaboration is so important. We may not think about fertility right at that moment, but don't completely forget about it either. If you can get one cycle in to get valuable eggs or valuable embryos or valuable tissues, that could potentially make a whole world of difference to your fertility journey later on in life. And yeah, that's something that I want to highlight, and I hope you tell everybody about this and create awareness on this. That's what happened when I had brain tumors. I was worried, but I didn't do chemo. Yep, exactly right. So yeah, bear in mind that there is always that option in the absence of any medical condition, or with that, you can always take charge of your own fertility journey, and we're all here to support you in that. I think that will be all for tonight. I've taken too much of everybody's time. This was meant to be a half-an-hour session. Thank you so much for joining me. Have a lovely night, and I hope to see you guys again sometime soon. Have a good night.